Hello, and welcome to Saving Sight: New Developments in Treating Retinal Diseases at Massachusetts General Brigham. I'm your moderator, Rachel Deere with DKB Med. Thank you so much for joining us. And now I'd like to introduce our esteemed faculty, Dr. Grayson Armstrong and Dr. Nimish Patel. Dr. Armstrong, Dr. Patel, thank you so much for being here.
Thank you so much for having me.
Thank you for having me as well.
And here are the faculty disclosures. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated. All activity content and materials are developed solely by the planning committee members and faculty presenters. This accredited activity is jointly provided by Partners for Advancing Clinical Education and DKB Med. PACE designates this enduring activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. And here are our learning objectives. Discuss how we can improve screening and prevent delayed treatment in both diabetic macular edema and neovascular age-related macular degeneration. Discuss consequences of delayed treatment initiation for patients with diabetic macular edema and neovascular age-related macular degeneration. Describe efficacy and safety of newer anti-VEGF treatments for neovascular age-related macular degeneration to increase treatment adherence, and evaluate the benefits of newly available treatment anti-VEGF options for diabetic macular edema. Okay, let's move on to our pretest. Everyone, you will see these questions again at the end of the presentation. Question 1. Which characteristic at baseline is associated with better visual acuity outcomes for people with neovascular age-related macular degeneration treated with anti-VEGF injections according to the CAT trial and others? A. Increased RPE elevation. B. Presence of geographic atrophy. C. Increased foveal thickness. Or D. Smaller CNV lesion size. Please answer now. Okay, question 2. What was observed after 1 year of treatment in a real-world sample of people with diabetic macular edema who delayed treatment greater than or equal to 24 weeks? A. Improvement in visual acuity and in macular thickness. B. Improvement in visual acuity but not in macular thickness. C. Worsening in visual acuity and in macular thickness. Or D. Worsening in visual acuity but not in macular thickness. Please select your answer. Question 3. Which of the following observations was made in the Tenaya and Lucerne trials of faricimab as treatment for neovascular age-related macular degeneration compared with aflibercept 2 milligrams every 8 weeks at 112 weeks? A. Macular thickness reductions from baseline comparable with aflibercept 2 milligrams every 8 weeks. B. Visual acuity gains inferior to aflibercept 2 milligrams every 8 weeks. C. About 50% of participants achieving dosing greater than or equal to every 12 weeks. Or D. Higher rate of serious adverse events with faricimab. Please select your answer. And question 4. In the PHOTON trial, which compared aflibercept 8 milligrams at 2 different intervals to aflibercept 2 milligrams every 8 weeks for treatment of diabetic macular edema, which of the following was observed at 96 weeks? A. Mean improvement in central retinal thickness inferior to aflibercept 8 milligrams at both intervals. B. Aflibercept 8 milligrams every 16 weeks was non-inferior to aflibercept 2 milligrams every 8 weeks for best corrected visual acuity. C, about 50% of participants receiving aflibercept 8 milligrams maintained dosing greater than or equal to every 12 weeks. Or D, higher rates of serious adverse events with aflibercept 8 milligrams. Thank you so much for answering those questions. Again, we'll revisit them at the end of the presentation. And now I'd like to turn it over to Dr. Armstrong, who will first talk about the prevalence of diabetic retinopathy and age-related macular degeneration. Dr. Armstrong?
Thank you. Thank you, Rachel, for this opportunity and for DKB Med. I want to set the stage by first talking about how prevalent diabetic retinopathy and age-related macular degeneration is amongst our patient populations. For those of you that are retina specialists, it may seem like every patient you see falls into one of these two buckets, and they are very common. But it is worth knowing that over the next couple of years, the rates of these diseases are only going to increase. We're here in 2020 or so, and we have a lot of patients with diabetes, many of which will have diabetic retinopathy, and AMD is relatively common worldwide as well. But if you look ahead to 2040, the rates are going to be increasing. Much of this is because our patients are aging, our population is growing, and with increased age comes increased rates and commensurate disease. Our patients really suffer from these diseases. They can be blinding, they can cause a lot of visual disability. And luckily, we live in a day and age where we can treat these things. And as the treatments evolve, which we'll learn about tonight, it's our duty as physicians to make sure that we get the patients into care, treat them adequately, and provide the best outcomes that we can. So I'd like to first thank the patients for coming and actually giving their perspective on these scenarios. We know that it's really important as physicians who see patients all the time to hear from our patients their stories. And we're often busy in our clinics hearing from our side our treatment diagnoses and recommendations, but we don't often get to sit there and listen to how these diseases are affecting the patients in their daily lives and what the burden of treatments are to them. So we're going to hear from them firsthand.
I was first diagnosed with diabetic retinopathy about 5 years ago. They casually mentioned to me, and I didn't really understand much about it at the time.
I used to go every year to the eye doctor, and annually in the beginning actually of the year in January. But when the pandemic happened, I skipped a year or two. And then my eyes started getting progressively worse.
When I was initially diagnosed with diabetic retinopathy, it was because I actually couldn't see out of one eye. And I just assumed that meant I could never see out of that eye again.
When I first went to the retina specialist, it was confirmed that I had dry macular degeneration. And unfortunately, after about a year, it turned wet.
I had wet AMD in the right eye, and that it appeared to be pretty far advanced.
As soon as I was told that I had a diabetic eye complication, it felt like my entire world was falling apart. I didn't understand that there were treatments. I had no idea that people got this diagnosis and could see again. So in those first beginning moments, I just wasn't sure what's going on, and it was petrifying.
What, in retrospect, I realized is that it would have been much more effective for me if I had some more information from, professional information, whether it be a video or a brochure, or something that I could take home and digest, rather than just a quick, this is what you got, this is what we're going to do, and it's not going to hurt, so don't worry.
Again, thank you to the patients who agreed to be a part of this and give their perspectives. We'll be hearing more from them later on in this episode. So here we are. Today's day and age, we live in a world where artificial intelligence is actually relatively mainstream. You may have heard of things like ChatGPT and other large language models, generative AI. But in medicine, we have it as well. And ophthalmology was an early leader in the use of artificial intelligence to screen patients for disease. Let's learn about how that's affecting care for diabetic retinopathy. So imaging for the eye. We can take fundus photographs of the eye and autonomously diagnose referable diabetic retinopathy. Referable diabetic retinopathy is defined as moderate non-proliferative diabetic retinopathy or worse, or patients with diabetic macular edema. And it's worth knowing that these photographs are read by the AI, and it does not require an ophthalmologist to overread the images. If you look at the data and you trust the data, it's more sensitive and specific than the average ophthalmologist looking at the eye, at least according to the studies. So it does a good job at figuring out which patients need to be seen by an ophthalmologist and which ones can stay home. And ultimately, it does tell us which patients need to be referred in or not. It's useful in a day and age where we already have a lot of patients with these diseases. Many of them are not receiving care. And so using AI to identify these patients in the primary care offices and other places is helpful. But more importantly, as the rates of these diseases increase, we're going to have more patients than we're going to have providers for. And so it's really going to make sure that the patients who are healthy can stay out of the office whenever necessary, and patients who do need the treatments can come and see us right away.
And Dr.
The
Armstrong, I
way,
have a question for you here.
yeah,
Can can this can this AI really be autonomous? Is it truly autonomous?
it's 100% autonomous. And it's the very first autonomous AI that was ever approved by the FDA. And as far as I know, it's still the only autonomous AI. Other fields like radiology or dermatology have assistive AI, where it will highlight a lesion or highlights a diagnosis, and ultimately the physician is responsible for using that information. But this is a totally autonomous device, and it's really kind of a game changer in terms of the use of AI in healthcare. Great question. So the way this works is that pixels and patterns from a fundus photograph are taken and fed through a neural network. It takes these little patterns with weighted neural networks and ultimately spits out a dichotomous outcome. Either the patient has diabetic retinopathy or they don't. Obviously, in this case, the patient does have diabetic retinopathy, and it would tell you that. And it's also worth knowing that it does that within about 5 to 20 seconds. So the patient's still sitting there after their photo was taken, and they'll get the results right away. It's not worth screening these patients with AI if they're already in our ophthalmology offices because they're sitting there with an ophthalmologist. So instead of putting them in the eye clinic, we're putting these things in places like internal medicine clinics, endocrinology clinics, diabetes education centers, diagnostic labs, and community health clinics. Patients where the patients are going for their care, especially for care for their diabetes, perhaps they're picking up their metformin, they're going to get their lab checked for their hemoglobin A1C. And so you capture them at their points of contact with the healthcare system. You screen them for eye disease, and if they haven't seen an ophthalmologist, this may be the first and only time they're getting eye care in the last couple of years or ever. The way this works is that the photos are taken. It takes generally 4 photos, a macula-centered photo of each eye and a nerve-centered photo of each eye. It runs that through the algorithm, and there's 3 outcomes that can occur. First, you can have no diabetic retinopathy. If that's the case, you can educate the patient on the finding, and you follow up again in 1 year and take another photo at that time. If they do have diabetic retinopathy that's detected, then of course you can refer them into an ophthalmologist for care and treatment. And if exam quality is insufficient, then you can try to dilate the patient in the primary care office if they're comfortable doing so. That might improve the rate of imageability. The reasons why poor image quality can occur is because of small pupils, cataracts, even things like vitreous hemorrhage. But unfortunately, if you can't see the retina, the AI isn't going to work. And so in those cases, it's often worth referring the patient in as well, because there might be something else that the ophthalmologist needs to be taking care of.
How easy are these cameras to use, Dr. Armstrong? Is there one that's better than the other?
So it's a great question. There are 3 different companies right now, all with different cameras that are used for this purpose. And all of them are excellent. The sensitivity and specificity of all 3 companies are very high, upwards of 80 to 90%, which means that it's really good at finding disease. It's really good at screening out normals as well. Many of them use a tabletop camera. So you can see here the Topcon NW400 is used by many. Some of them use a Canon tabletop camera. But one of them, the AI DS, which down there is called Aurora AI, uses a handheld AI fundus camera. And this is a portable handheld camera that can be marched around a clinic, and you just take a little photo of the eye. It's incredibly convenient. All of these things take roughly 5 to 8 minutes per patient. And if you get really good at taking these photos, it can be even faster. We've started using this in our clinics, and we found that at the beginning of using these cameras, it takes a non-ophthalmic tech, usually like an MA in the office, medical assistant, about 8 minutes. But once they get really well practiced and well versed in this, it can be as low as 4 to 5 minutes. There is currently a large AI quality improvement protocol that's being implemented at multiple institutions. 6 healthcare systems to be exact, including Mass General Brigham here, where 240 cameras are being rolled out at all of these facilities. To date, there are 171,000 patients with diabetes collectively at these centers. We've screened about 25,000 patients so far, and the more than mild diabetic retinopathy detection rate is about 21%, which is on par with other studies. That's what it should be. It's worth knowing that the insufficient imageability rate is usually around 25%. Again, that's because of cataracts or patients that are coming in with vitreous hemorrhage and small pupils. But of the patients that are being screened, about 21% are screening positive, and that means that 79% are screening negative and can stay home because they have a relatively healthy eye exam in terms of diabetic retinopathy. We do counsel the patients that it's not checking for glasses, not checking for glaucoma, so there are other things they might want to see their ophthalmologist for, but at least their diabetic retinopathy is taken care of. And the way we see this is it's kind of like a lab test. If you check your cholesterol level, we can tell you whether you have high cholesterol or not, but we're not going to tell you whether you're going to have a heart attack or what your hemoglobin A1C is. So it's a one test, one result kind of thing. The Stanford group, separately from this large quality improvement initiative, employed the same cameras that we're using. And they found in the early days before the AI, they were using fundus photographs and humans to read the images. At that level, they were finding about a 5.6% diabetic retinopathy rate in the population that needed to be referred in. But after they implemented the AI, the rate of diabetic retinopathy that was being referred in bumped up to 19%. And the question was, are these patients that are sick that otherwise weren't being detected before? Or are they overcalling these patients and actually screening a lot of normal patients? To try to get the healthy normal patients out of that population, they had a pretty innovative way of screening these patients, which is called a hybrid human AI interface. So what they did is they had the AI take a photograph of the patient's eye. Using the AI alone, the sensitivity was about 95.5%, and the specificity was 60%, which means that the positive predictive value is 47.7 or about 50, meaning 1 out of 2 patients that came into the office actually needed to be there, but the other 50% were actually healthy and didn't need to be there. So they implemented a human overread, where anyone who was negative would be screened again in a year, but anyone who was positive or ungradable had an overread by an ophthalmologist. That ophthalmologist would look at the photo and make their own determination about whether the patient was healthy or whether they needed to be seen. For those that were positive or ungradable, even after an ophthalmologist reviewed it, they referred those patients in, and those who screened negative at that point were allowed to be screened again in a year. At this point, they found that the sensitivity remained incredibly high, but the specificity improved to 98.2%, which provided a 95.5% positive predictive value rate, meaning that only 1 out of every 20 patients who was referred in did not need treatment for diabetic retinopathy and did not have more than mild disease. And 19 out of 20 patients actually needed to be there in the office. This same model was studied in Singapore and found to be a very cost-effective way of providing care. But it's not overall 100% perfect, because when they looked at this, they tried to determine which patients were more likely to follow up, those who only had an AI result or those who had the AI human workflow employed. The patients who came in and were screened by the AI got a result within 20 seconds. And so while they were sitting there, they learned about their diabetic retinopathy risk, and they were told to see an ophthalmologist. But those who had the human overread usually got the results within 1 to 3 days. And so the patient was already home. This was out of sight, out of mind. And who knows if they actually got the result on the back end. And so the patients who did get the AI result were much more likely to follow up. 35% ended up showing up in the clinic, whereas only 12% of patients who were screened with the AI hybrid workflow showed up in their follow-up. AI is bound to make a huge impact in ophthalmology in the future beyond diabetic retinopathy, and work is going on in this space. It can be used to screen for macular degeneration. It can predict who is going to need injections within the next 24 months. It can predict progression to late neovascular AMD and progression to geographic atrophy, as well as predicting which patients are at highest risk for accelerated disease. We're lucky to live in a day and age where we don't just have to screen for this, we can treat it. And so here are some of the treatment options in the real world. And first, we're going to hear from some patients about their experiences with treatment.
It's very inconvenient trying to read with a magnifying glass.
It's debilitating in this disease. And certainly for people that don't have a partner in the house that can drive them or someone designated to drive them and take care of them, then I would think it would be extremely difficult.
When you see someone's hand approaching your face with a long syringe, there's a certain question you have in your mind about just what's this going to feel like.
When I first got the news that I would need an eye injection, that was very scary, even though I was very used to injecting myself with insulin. Thinking about a needle going to my eye sounded like the worst possible thing.
I have marked on my calendar when I expect to have the next injection. So vacations are scheduled around that date. All social activities. So when I was working, work was scheduled around. I would usually take the day off. And even now, I consider that day a down day. So when I have the injection, that's it. That's all I do that day. Sometimes the day after too.
When I came home, my whole day was ruined because I couldn't do anything other than, lay down and close my eyes and sleep.
Typically that day I would just go home, turn off all the lights, and I couldn't do anything else. The following day is when I would typically try to start to pick things back up, but I would still have an eye that was sore.
And thank you again to our patients for their experience. It's rare to hear such candid experiences with people's experience with treatment. So here we have the first generation FDA approved and off-label uses of anti-VEGF for the treatment of diabetic retinopathy and age-related macular degeneration. It's worth knowing from the outset that bevacizumab is a non-FDA approved treatment, but it's commonly used in our clinics for many reasons, including cost to our patients. But all of these are antibodies or antibody fragments that are used to target the VEGF molecule. And this is one of the molecules that helps drive the diseases of diabetic retinopathy and macular degeneration. And you see that each one has variable metrics, including the time that it suppresses VEGF within the eye and which targets they use. But all of them are injections of medicine into the eye with a needle, and patients would benefit. And we tend to dose these based on the need and the disease activity afterwards. While those are well treated and well tolerated in patients with relatively low risk profiles, there are some things to know. If you have a patient in front of you with diabetic macular edema, some patients may be hesitant to start treatment right away. So there was a study that was done on about 500 patients that looked to see what happens if you treat them right away versus waiting to treat them later. So they looked at a cohort of patients that had immediate treatment versus a delay in treatment beyond 24 weeks. And what they found, if you looked at the bottom left-hand side here, is that patients with early treatment at the time of their first injection had relatively poor vision that improved remarkably by the 1-year time point. However, the patients who delayed treatment had decent vision at the beginning, comparable to the first group, but unfortunately their vision declined and did not improve unlike the first group. So what that means is that if you delay treatment, your patients run the risk of not gaining vision back, unlike their counterparts who initiated treatment earlier on.
Is that what you're seeing in your clinical practice as well? And what about after 1 year? What do you think happens after 1 year?
It's a great question. So in my clinical practice, I do see that if you have a patient early on, it tends to not affect the architecture of the retina quite as much, and it has a better chance of improving. Beyond a year, I guess I don't have the study results in my own patients to show, but I would say that these results probably persist beyond a year. What do you think?
Yeah, I actually agree. I think sometimes we're colored by Protocol V from the DRCR, which says that you don't need to treat patients who are 20/25 or better, but some of that data is limited by short-term follow-up. And I think the longer I go on, the more I see that even patients with some diabetic macular edema over the long run will develop some level of atrophy, and that you may be better off with more aggressive earlier treatment and preventative treatment rather than waiting until the edema has been there for a long time.
And I think that makes sense, right? Because once you have the actual retina basically destroyed, the architecture, the retina is a very sensitive tissue, and the cellular adhesions just get disrupted by that leakage of chronic fluid, and then you get the exudates. And so I agree. Sometimes I think it's worth trying to get these patients in early. And if you look at the central subfield thickness measures down on the bottom right, you also see that for the patients with early treatment, they had a remarkable improvement in their retinal architecture and the thickness of the retina. but those who delayed their treatment did not have as good of outcomes. In fact, they had no real improvement. When you turn your attention to neovascular age-related macular degeneration, many of the studies ask that you do a series of injections, usually monthly at the beginning, and then dose it based on the patient's outcomes. However, is that what we're doing in real life? I mean, it's hard to keep patients following up like a clinical trial, and not all of us are totally tied to protocols. And so if you look at real-world data, over 73% of patients only receive up to 5 injections in the first year of treatment. That's really substandard compared to the clinical trials if you look at the protocols. And then the question is, does this affect their visual outcomes? And unfortunately, the answer is yes. If you look at change in vision based on the number of injections on average that patients receive for neovascular AMD, you see that patients with 4 to 5 injections end up losing vision in the long run, but those with more injections in that first year actually gain letters of vision. Is this what you see in your practice, Dr. Patel?
Yes, I think it is. And I think similarly that if you can get the retinal architecture to be as normal as possible, as early as possible, that prevents some of the cellular damage and atrophy and fibrosis that tends to limit the vision in the long run. So I think I try to dose based on the label, at least initially, and then start to extend once you've reached that maximal anatomic improvement and try to extend fairly carefully.
Mm-hmm. Yeah, and I think there's many reasons that we'll hear about in just a second as to why people are either lapsing from care or physicians may not be totally on top of the protocols in terms of treating. But the better we can do for our patients, the better their vision is going to be. This just shows the central retinal thickness changes based on the number of injections in the first year for patients with neovascular AMD. The more injections you give, the more improvement you see in the thickness of the retina. And this just goes directly to show that that retinal architecture does have a chance to improve if you catch it early and often, and you're treating it relatively frequently. But that's a high treatment burden, right? 14 injections in a year, you're seeing them more than every month, basically. These patients are going to be your new best friends for a while, and they may get a little bit tired of it. There's a few things to know when you're seeing a patient in front of you that can help predict patients' visual outcomes in the long run beyond just the number of injections. Patients with smaller CNV lesion size or leakage area in multiple trials are shown to have better visual acuity outcomes. There's also better visual acuity at the outset, means better visual acuity on the back end. We'll see that graphically in just a second. Patients who present with neovascular AMD at a younger age also have better visual acuity outcomes, and those with occult CNV versus the classic CNV tend to do better as well. Unfortunately, if you have an increased RPE elevation, if you have presence of geographic atrophy, or increased foveal thickness of the retina as compared to other patients, those patients end up doing worse. And again, I'd just be curious, Dr. Patel, in your practice, are these the metrics that you tend to see that correlate with vision outcomes? And do you use these features clinically to try to explain to their patient or to your patients their outcomes?
Yes, I think there are a few of them that are more pertinent than others. I think the fluorescein angiography has decreased in most practices due to the need for nurses and the improvements in resolution on the OCT. So I think we're really not tracking maybe the size of the CNV or the occult or classic as much as we used to in most patients that the diagnosis is clear. But the one I do talk about is younger age tends to be a good predictor for maybe having better outcomes and needing less injection. And of course, geographic atrophy. There are some new treatments for that out there, so that kind of shifts the conversation slightly nowadays. But as soon as I see geographic atrophy are already present, or if there's a really high pigment epithelial detachment and there's a potential for a retinal pigment epithelial tear, those are some other things I may talk to the patient about their prognosis, those having a potential worse outcome. But usually the younger age is, and I also think that one that wasn't on here was how fast they present with their vision change or distortion. So if you see subretinal fluid and without chronic intraretinal fluid and maybe a small good retinal thickness, you're probably likely to do better in the long run than someone who waited a long time, already has chronic atrophy and intraretinal fluid.
Yeah, I totally agree. So here we see graphically just what I meant by saying that if a patient presents with better vision, they end up with better vision. And this tends to be true. What's, I guess, ironic about this is that patients with better vision may be more hesitant to get treated because they don't maybe detect as much going on. But if you do have better vision at the outset of the episode of neovascular AMD, they tend to have better vision in the long run. Perhaps that's partly the architecture, partly that's fibrosis, might be the hemorrhage, photoreceptor loss, etc. But this is something that you can use to counsel your patients and try to encourage them to get treated early, especially if you're having a little hard time because their vision's pretty good. Not every patient wants to be treated every month, and it's hard to keep patients maintaining these schedules on a chronic basis. There has been a study that shows that for patients with age-related macular degeneration, a lapse in vision or a lapse in treatment leads to a lapse in vision and worsening retinal thickness. So here you can see that there are two populations. One is a control group and one is a patient group that lapsed to care. For the patient control group, after they've been treated for a while, their visual acuity remains relatively stable in this cohort. However, the patients that lapsed care and came back after they had worsening of disease maintained a worsened visual acuity outcome, and that's statistically significant, which is signaled by the little stars on this chart on the left-hand side. Fortunately, the retina can improve structurally. So on the right-hand side, you see that if they lapsed in care, their retina became thicker, probably with subretinal or intraretinal fluid. But after it was treated, the retina architecture did kind of decrease and go back to relative baseline for that patient population. But as we just saw, their vision was permanently affected. So this is
Dr. Armstrong, how do you manage these patients who lapse follow-up? What would you say are kind of the most common causes, and is there anything that you can do to rectify those when you see the patient?
It's a great question. This is a perfect time. It's almost like you knew the slide was coming, Dr. Patel. There's many reasons why patients have a hard time getting into care and maintaining the schedule. Some have personal health conflicts. AMD may not be the only thing that's going wrong with these patients that are older. Non-adherence alone is a problem. Perhaps this is because they have family issues, they have a kid at home, they have elder care responsibilities. Travel may be an issue for some patients, financial access issues. But for 50% of these patients, we just don't know. And in my experience, what I would tell the patient is that, if you're able to maintain these visits, they're able to maintain the best possible vision. And it can be challenging. And I'll offer to do whatever it takes to try to see them. If they can't make a visit, they can call and reschedule with myself or a colleague. They can try to find ways to plug themselves in according to their convenience or their travel schedule. And if things change, I tell them to let my office know right away. But it can be difficult to maintain this schedule. What do you do, Dr. Patel?
Yeah, I think it can be quite challenging. I usually try to tailor my treatment interval to the patient. And if they're really having a hard time, try to extend them and have a conversation with them and also their caregivers, who are usually the ones bringing them in, about what's feasible, what can be done, really trying to then do things that can extend the interval, like doing bilateral injections on the same day, maybe potentially going to some of these newer agents that we're going to talk about and seeing what else can be done for them. And of course, social work can sometimes help with transportation and rides.
Mm-hmm. Yeah, the same problem exists in diabetic care. I don't know if that's in your experience to be true, but I have found that to be true. It's hard enough to get these patients into the office because they're often younger than our AMD counterparts, so otherwise they may be relatively healthy beyond the diabetes. And as you see on this slide, it's a lot of information, but the big takeaway is that patients that are in less socially advantaged cohorts tend to have higher lapses in care. And so whether that's various socioeconomic backgrounds or whether that's certain demographics, patients who are from less advantaged platforms and backgrounds tend to show up less often, which can result in worse visual outcomes. And again, for diabetic macular edema treatments, there are many things that can keep them from treatment as well. Some of these patients get hospitalized, whether it's for their diabetes or something else. Some of them just refuse or miss treatment. Some have financial access issues, and some have prolonged travel without treatment. They may be snowbirds and leave here in Massachusetts, they may go down to Florida, and then if they have a doctor locally, that's great. If they don't, they may be missing like a couple months worth of treatment, and that can affect their vision again. A lot of these things we just don't know. There's a large unspecified here, so I think more research needs to be done. So at this point, I'll hand it over to Dr. Patel, and he will take it away, talking about the changing landscape of anti-VEGF treatment.
So I'm excited to be the one getting the cool part of the talk, which is the changing landscape of anti-VEGF treatment. It's a really exciting time to be a retinal specialist. There's a lot of new treatments that have been recently FDA approved, and there's also many treatments in the pipeline in different classes of medication. So we're going to talk about a couple for age-related macular degeneration, diabetic macular edema, and diabetic retinopathy. So here's one video from a patient that can discuss some of their experience with this conditions and their treatment.
When I first started getting eye injections, I had an eye injection each eye every month for 4 months. After that, they started getting spaced out.
After 3 months on Avastin, my doctor suggested that we try Eylea because we weren't seeing the kind of success he was hoping for on Avastin, and he thought perhaps Eylea would give us a little more time between injections. I think at one point we even were able to space it out to 6 weeks. And that was really helpful, even though it was 2 extra weeks.
Spacing out eye injections really changed a lot for me. It didn't seem like it would be a big deal, but making an appointment going from every 4 weeks to 6 weeks to then eventually 8 weeks meant that I had more time in between just to live my life.
Getting less frequent shots would dramatically change my life, of course. Nobody wants to get up and go to the doctor every 2 weeks.
Eye appointments in general, even before you get into an eye injection, always is a lot of things involved. You're getting your eyes dilated. It's a process. You have to take time off to go to a doctor's visit. So before I even get to the procedures and the screenings of an eye appointment, I have to go through the eye appointment itself. With the eye injection on top of that, that not only takes up almost a half a day of my time, but also I'm restricted from doing anything else. So the more time in between those eye appointments and eye injections, the more time I have to just be myself and exist.
I look forward to the day that somebody comes up with a medication that can extend the injections out for me.
Okay, and we're very appreciative of these patient stories to help us understand their disease. So there are a couple new treatments, and some of them include aflibercept 8 milligram, the ranibizumab port delivery system, and faricimab. So we'll just go down by these one by one. Aflibercept is well known to us in 2 milligram form, but now there's an 8 milligram form that's in 0.07 milliliters versus 0.05 for the 2 milligram. And what they've been able to do is achieve a 4 times dose with a very small increase in volume. And that, in theory, can potentially include longer durability and more medication and potential better efficacy as well. The port delivery system is an implantable device that can be refilled in the office. It's implanted in the operating room and then refilled on an every 6 months basis. The advantage of this is that it can be given as a slow elution of medication rather than bolus doses at an injection. And this could potentially decrease the number of injections patients require. And then we have faricimab, which has a few different indications: neovascular AMD, diabetic retinopathy, as well as retinal vein occlusion. This is one of the first bispecific anti-VEGF agents, where it not only inhibits VEGF, but also Ang2 on the same molecule. And Ang2 has been shown to be important in endothelial stabilization of blood vessels, and particularly in diabetes, that's a big problem.
Have you had experience with all of these, Dr. Patel?
Yes, I have. I have used the faricimab and I have used aflibercept 8 milligram. I've not personally implanted the port delivery system, there was a recall on it right as it got approved, where there was a septum dislocation. However, it is now back on the market. So we'll be looking out for some of these patients that are good for that treatment. Some of those are particularly some patients who really struggle to get into the office and may benefit from a one-time procedure. There are some safety issues with conjunctival erosion, but that's still something they're working on, and we'll have to see how it goes in the long run. But it will be kind of interesting to see where we go from here with these new agents as well, because there's a potential for longer durability, and we're not sure how that will affect the need for some of these surgical therapies as well. So this is the Tenaya and Lucerne study for neovascular AMD. There were 2 parallel phase 3 studies for faricimab against aflibercept 2 milligram dosed every 8 weeks. Now, this is the study on the trial design, which is kind of interesting, where there was an initial loading phase, and then for the faricimab arm, there was a fixed dosing schedule, but then there was also a variable dosing arm that was based on the investigator evaluation and the OCT criteria. And the primary endpoints were averaged out from 40 to 48 weeks. And we were looking at things like central retinal thickness and best corrected visual acuity. So interestingly, we did find that in neovascular AMD, that faricimab maintained similar outcomes in terms of best corrected visual acuity and central retinal thickness, even with less injections. In the aflibercept arm, they had about 15 injections, while faricimab up to Q16 weeks had 10 injections through 108 weeks. So that's a significant reduction in treatments while maintaining good efficacy as well. I think this is one of the more really shocking parts of these studies, where initially a lot of us were treating patients every 8 weeks, every 12 weeks, and very rarely every 16 weeks. And now we've been able to achieve these extended dosing intervals in the clinical trials. Through week 112, a very significant proportion of the patients achieved Q16 weeks with faricimab at 63.1%. And if you add that with the Q12 week patients, that's 77%. Over 3/4 of the patients are achieving Q12 weeks or better. Now, Dr. Armstrong, in your clinical practice prior to these medications, do you have a sense of, is that a lot? Is that a little? How many of your patients were really getting to Q12 weeks prior to this?
You know, prior to this, I'd say it was not the norm for patients to be able to reach Q12. And patients wanted it. Many wanted to be able to get there. Occasionally, the lucky patient would make it there or beyond. But I've got to say, these trial results were really, really reassuring to patients to see. It was nice to see as a clinician. And diving into the data, it's reassuring to know that these patients had good clinical outcomes despite these really extended treatment protocols. So in my practice, I think that we are doing a better job at extending these patients now, which was not quite as common in the past.
And what's your general criteria for extending a patient? Let's say you see a patient that comes back with more fluid or decreasing vision. Do you think more about fluid or vision or both when it comes to extending patients?
For me, you know, if it's a little bit of subretinal fluid, especially away from the fovea, I'm a little more tolerant of that. You can't always dry up every patient. And I think it's okay. There's some thought that maybe a little bit of fluid and a little activity of the membrane is okay, as long as the patient is able to see and it's not affecting the intracellular or intraretinal fluid. You know, if a patient comes back with worse vision, or they're having significant worsening in fluid and a significant worsening in the intraretinal component of the fluid especially, I think that you need to reevaluate and maybe cut them back a little bit, put them on a tighter schedule, or at least maintain them. Don't try to extend past that. Every eye is different. Every eye is unique. But these medicines, while they do give you that kind of option of hopefully extending to 12 weeks and beyond, it's not a guarantee. So you really have to do it per patient, per eye, and make sure that you're not hurting the patient.
Yeah, I do something similar. And in these trials, what they looked at is both having a central retinal thickness increase and a vision decrease. So they were going based off a couple different criteria, and they showed that that's safe and effective in extending patients. So it's something that we're going to think about more, I think, in our own practice going forward, not just following the OCT or the vision, but using some combination of both.
Mm-hmm.
And so here are the adverse events in the study. We're all very in tune to intraocular inflammation, as some of our recently approved medications have had issues with this, particularly vasculitis. And so uveitis, vitritis, iridocyclitis, they were all relatively equal amongst both treatment arms. And then here we have the corresponding studies for diabetic macular edema, Yosemite and Rhine, which looked at faricimab again against aflibercept on a fixed dosing schedule. Very similar trial design where you had a set of loading doses and then a variable dosing arm based on these retreatment criteria, as well as a fixed dosing arm of faricimab and a fixed dosing arm of aflibercept 2 milligrams every 8 weeks.
So how did they decide, Dr. Patel, the kind of the variable dosing arm for the faricimab there in the middle?
Yeah, and that's what we were talking about earlier. It's a mixture of set criteria based on the central retinal thickness and vision. And often what they were asking for is a gain of central retinal thickness within usually 50 to 100 microns and a certain percentage letter loss, sometimes 5 or 10 letters, depending on the study and the trial design. So that's where they've been deciding. And if you meet the criteria for those, you can get a rescue injection. And if you don't meet the criteria, then they recommend not doing an injection. Of course, in all these studies, there's an investigator discretion where if the investigator feels there's some other reason, let's say a new hemorrhage that may require injections, or let's say neovascular glaucoma, of course, they're free to do so. But these were pre-specified set guidelines that if you followed, they thought that they could be able to extend the patients even longer than what they were already on.
Mm.
And so here we see the mean adjusted best corrected visual acuity in ETDRS letters. And as expected, based on what we saw in the macular degeneration data, that the visual acuity was relatively equal amongst both arms. So again, we're able to potentially extend patients and give less injections while maintaining good vision. This one I think is a little bit interesting here is you look at the mean CST change. I think what jumps out to me on this graph in the Yosemite trial is actually the faricimab arms had a slightly faster decrease in the matched phase. So when you're giving the injections in the same intervals, it looks to me that the faricimab is a better drying agent in diabetic macular edema. And maybe that's because of this Ang2 factor that's also at play in diabetes and endothelial and parasite stabilization.
Yeah, and as we talked about earlier, I think that maintaining the retinal architecture and drying it out fast can be helpful in the long run for some of these patients.
Yes, and I think the other thing that's slightly interesting to me here is when you look at the pattern of the fluid in some of these patients, you can see that it's actually increasing in between doses. I think what I had thought initially that was if you give patients Q8-week dosing, that in between they're probably around the same. But if you look at these Q8-week arms, there's kind of a sawtooth pattern happening there where it's going up and down. So it's potentially that some patients do need more frequent treatment, or in between treatments, there's an increase in retinal thickness. So there could be a need for some longer acting medications here.
Mm-hmm.
Similarly, we could get a very large proportion of patients to the Q16 and Q12 weeks, both over 75% in the faricimab arm versus aflibercept Q8 weeks. The mean number of injections you can see there in year 2, which is important because we know that usually in diabetes, there's more injections in year 1, and in year 2, there's a decrease. But in the variable dosing arm, they were able to go to just 3 injections average in year 2 for those patients. What do you think, Dr. Armstrong? Does that mean something to you? Is that about what you're doing or better or?
I mean, I think that this is in a clinical trial scenario, like in some ways the best possible. I'm not always getting there, but for the patients that are able to extend to this, I can tell you they're very appreciative. A lot of these patients have very busy lives. They're often working age populations and they're trying to get their kids taken care of, get them to school, get them to soccer practice. And they are not super excited about coming in every 4 weeks, every 6 weeks, every 8 weeks. And so for the patients that we are able to get them onto these newer, longer acting medications and that they're doing the job they're supposed to, extending, it is incredibly exciting for them.
Yes, and then I would just touch on here the same about the safety, that it was fairly comparable amongst both. So now we're going to move to aflibercept 8 milligrams, which is this novel intravitreal formulation that delivers 4 times the prior aflibercept 2 milligram dose. And the thought being that it can provide longer, more effective vitreous concentrations. One of the benefits of aflibercept at the beginning, as if you saw in Dr. Armstrong's slide, is that the half-life is potentially longer than some of the other medications, and it's a pan-VEGF blocker, so it blocks other types of VEGF, not just VEGF-A, and also potentially has some other effects in terms of improving the leakage from the blood vessels.
And you did note here that it is a slightly higher volume of medication, right? Have you noticed any issues with the higher volume of medication for these patients?
Yeah, I actually have not noted that, and I was a little bit careful because I'm always trying to avoid, AC tapping the patient or doing a paracentesis after the injection. So I was watching pretty carefully. For the first few that I did, I kept the patient in the room a little bit longer and just, double checked their vision, made sure they were still getting perfusion. I think there are some concerns that we'll have to check in the long run if there's any signs of glaucoma. Maybe if there's a patient who has high pressure, I wouldn't necessarily jump right to that and have the higher volume. But we know that other injections, even higher volumes, for example, some of our geographic atrophy drugs are 0.1, and so 0.07 should be reasonably safe. Then we go to this PULSAR study, which is the study for 8 milligram of aflibercept in neovascular AMD. This was a multi-center randomized double-masked study in treatment-naive patients and who are randomized to get 3 different arms. One is aflibercept 2 milligram every 8 weeks. The other is 8 milligram of aflibercept every 12 weeks, or 8 milligram aflibercept 16 weeks after 3 monthly injections. And then they looked at the end of the study at 96 weeks, same endpoints. And what they found again was there is non-inferior best corrected visual acuity outcomes with these medications, and also similar reductions in central retinal thickness. Now, I think this is a slide that's quite shocking when I first saw it, and to a lot of folks out there, is we weren't really even talking about Q20 and Q24 weeks, but we did see at the 96-week mark, there's a fairly high percentage of patients who, in all aflibercept 8 milligram patients, 47% were getting over Q20 week intervals. So that's quite good in terms of extending the patients and potentially improving compliance. Dr. Armstrong, I think one question that's come up here, so let's say you had one of these patients who can go Q24 weeks, would you still see them in between? Or would you say, okay, I've extended you from 20, we'll just see you back in 6 months?
That's a great question, especially for macular degeneration, where like one event can be relatively devastating. Then again, how often am I going to need to see them to detect that one incident if it ever does occur? And it's a conversation with my patients. I offer this to patients and I say, hey, look, I know you're busy, but if you don't mind coming in, maybe in 3 months we'll check and make sure that things are going the way we want, and then we can extend it a little further. Most patients are comfortable with that. They understand the risks are real. They understand that coming in is maybe a little inconvenient for them, but to save vision, it's not so bad. And eventually, if I felt comfortable, I would send them out and see them back in 24 plus weeks if we can. So I think it's a per patient thing, and I talk to them about it as an option. I just don't want them to get too far out of my control. And it's maybe my fear, right? I'm treating my own fear by seeing them more often to make sure that they're safe, even though, according to the data here, many patients can extend that far without needing to necessarily be seen every 8 weeks, every 10, every 12 weeks.
Yeah, I've actually found that some of these patients, they're really happy coming in and not getting an injection. So it's sometimes there's something therapeutic for them as well, coming in and not getting that injection and feeling good about their eye and feeling good about their ocular health rather than every time they come in getting an injection. So some of my happiest patients are the ones that I say, "Oh, no injection today." And so if they're able to come, it doesn't seem to be that much of a burden for them, and in fact, potentially can make them happier. And so similarly here, we saw essentially equivalent ocular adverse events amongst the different treatment groups. And all 8 milligram patients, when you pull them together, had very acceptable rates of some of these adverse events. And then what they did look at is patients with pressure 35 pre or post injection, and when we may be concerned about this higher pressure, and it seems to be around the same for all. And then we see that the visual acuity gains were maintained towards the end of the study. And this is a little bit, a lot of information here, but we're talking about photon now, which is diabetic macular edema. And we're looking at these changes based on different quartiles. So the quartiles are based on central retinal thickness, and we're seeing how patients do across the different arms. And I think the thought here is that the patients who had really severe disease may do a little bit better than those who have very mild disease, getting a higher concentration of the medication. So overall, there was non-inferior outcomes in diabetic macular edema as well, with these similar dosing schedules. There were also similar anatomic outcomes as well, and similar safety profile. The key takeaway here is that, again, there's up to 6 fewer injections with the aflibercept higher dose patients, with 89% maintaining greater than Q12-week dosing intervals with comparable safety. So I can go through some of the key takeaway points for both of our sides of the talk. Is that delayed initiation of treatment for DME is associated with worsening visual acuity and worsening macular thickness. So there is a need to get these patients treated early and often to restore the retinal architecture and visual function. For people treated with anti-VEGFs for neovascular AMD, smaller lesions are associated with greater improvements in visual acuity, as well as other things like younger age and better visual acuity at presentation. In the pivotal trials for faricimab, the faricimab Q8 weeks led to similar reductions in macular thickness as aflibercept 2 milligrams with non-inferior gains in visual acuity. And for 8 milligram aflibercept for DME, it was Q16 weeks was non-inferior to 2 milligrams dosed every 8 weeks for visual acuity with similar anatomic outcomes. So for both faricimab and aflibercept 8 milligram, we're finding similar anatomic and visual outcomes for patients with extended dosing and less injection. Dr. Armstrong, do you have any closing thoughts or parting words based on this presentation and all this data that we reviewed?
Well, I think first and foremost, there's a lot of new medications and treatments that are on the market and many more on the horizon. And these really do stand to change the paradigm in how we're treating patients with AMD and diabetic macular edema. It stands to improve our patients' compliance by giving them longer treatment intervals. It stands to improve their vision outcomes in the long run as well. And I'm just excited to be in a day and age where AI can also help to find these patients and bring them in where we couldn't have that before. What about you?
Yeah, you said it perfectly. I think the age of AI is upon us, and we need to be able to integrate this into our clinical practice and work with the technology to help many patients who don't even ever make it into our offices get in to see us, and we're hoping for longer duration of treatments, less injections for patients, and it's seeming like we're moving in that direction with some of these new therapies.
I agree. Yeah, it's a good day to enter the field of ophthalmology with an eye condition.
And we're now going to hand it back to Rachel for the post-test.
Thank you, Dr. Patel, and thank you, Dr. Armstrong. And now let's revisit those post-activity questions. Question 1. Which characteristic at baseline is associated with better visual acuity outcomes for people with neovascular age-related macular degeneration treated with anti-VEGF injections, according to the CAT trial and others? A. Increased RPE elevation. B. Presence of geographic atrophy. C. Increased foveal thickness. Or D. Smaller CNV lesion size. Please submit your answer. Dr. Armstrong, what's the correct answer and why is it correct?
The correct answer for question 1 is D, smaller CNV lesion size. Multiple trials, including CAT, Harbor, Marina, others, have all shown that the smaller the size of the choroidal neovascular membrane, the better the visual acuity and clinical outcomes.
Thank you, Dr. Armstrong. Here is question 2. What was observed after 1 year of treatment in a real-world sample of people with diabetic macular edema who delayed treatment greater than or equal to 24 weeks? A. Improvement in visual acuity and in macular thickness. B. Improvement in visual acuity but not in macular thickness. C. Worsening in visual acuity and in macular thickness. Or D. Worsening in visual acuity but not in macular thickness. Please select your answer. And Dr. Armstrong, what's the correct answer here and why?
The correct answer for question 2 is C, worsening in visual acuity and in macular thickness. The study of about a 500 patient cohort found that if you delayed treatment for macular edema from diabetes, unfortunately, they did not have return of their visual acuity compared to patients who had initial early intervention for their diabetic macular edema. And that's also true for their macular edema thickness.
In question 3, which of the following observations was made in the Tenaya and Lucerne trials of faricimab as treatment for neovascular age-related macular degeneration compared with aflibercept 2 milligrams every 8 weeks at 112 weeks? A. Macular thickness reductions from baseline comparable with aflibercept 2 milligrams every 8 weeks. B. Visual acuity gains inferior to aflibercept 2 milligrams every 8 weeks. C. About 50% of participants achieved dosing greater than or equal to every 12 weeks. Or D. Higher rate of serious adverse events with faricimab. Please select your answer. Dr. Patel, what is the correct answer and why?
The correct answer is A, macular thickness reductions from baseline were comparable with aflibercept 2 milligram Q8 week in Tenaya and Lucerne compared to faricimab. The reason this answer is correct is that the visual acuity gains were similar, and over 50% of the participants achieved greater than Q12 week dosing, and there were relatively equivalent rates of adverse events in both studies.
And question 4. In the Photon trial, which compared aflibercept 8 milligrams at 2 different intervals to aflibercept 2 milligrams every 8 weeks for treatment of diabetic macular edema, which of the following was observed at 96 weeks? A. Mean improvements in central retinal thickness inferior to aflibercept 8 milligrams at both intervals. B. Aflibercept 8 milligrams every 12 weeks was non-inferior to aflibercept 12 milligrams every 8 weeks for best corrected visual acuity. C, about 50% of participants receiving aflibercept 8 milligrams maintained dosing greater than or equal to every 12 weeks. Or D, higher rates of serious adverse events with aflibercept 8 milligrams. Please select your answer. Dr. Patel, what is the correct answer here and why?
The correct answer is B, that aflibercept 8 milligram Q16 weeks was non-inferior to aflibercept 2 milligram Q8 weeks for best corrected visual acuity. And that's because, again, greater than 50% received greater than Q12 week dosing. There were equivalent rates of adverse events, and there were relatively equivalent central retinal thickness.
Dr. Armstrong and Dr. Patel, thank you so much for a wonderful presentation.
Thank you so much for having me.
And thank you for having me as well.
And thanks to all of you watching. Please click the Claim Credit button to access the evaluation if you'd like to claim your credit. And please be on the lookout for a 30-day survey. These surveys really help us while we develop future programs. We hope to see you there. See you next time.